99.7 FM.
Yeah, another one I'm falling in love with all over again. Familiar with Praise. Ultimate Health on Joy 99.7 FM. Yeah, I started with thoughts and reflections. I remember when my dad died, the pastor who preached
you know he's another
in Ghana, Osofo Bodai, he says, Wala ma kemabo. Your life, your breath, everything you consider to be life is loaned to you. Ma kemabo. And at any point in time, the good Lord can ask. Why don't you join him up there? And our thoughts go with the family of Christian Achu, Ghanaians generally. All right, Ultimate Health on Joy 99.7 FM with me, Naughty by Nature. Today I swing to take a look, to focus, to zoom on geriatric medicine. Yes, healthcare needs of the elderly. Are they unique? Are they special? And if indeed they are, do we make provision for their needs? And do we fine-tune the delivery of healthcare services to this special group? In the studio with me, I have Reverend Dr. I always ask the Reverend, am I right? Reverend Dr. Ernest Enim Opare. Now, I'm always glad that I'm able to call him a specialist family physician. He's with the Kolibu Polyclinic Family Medicine Department. Alongside him, another good friend of the program, Dr. George Akwa, is a community medicine resident with the Kolibu Teaching Hospital here in Accra. He has decided to take a haircut. I consider them both much younger than I am, but it's good to have you in the studio, gentlemen. George.
Sir.
And he calls me sir. Okay, you've taken a haircut.
Sir, it went on its own.
It went on its own. I just don't understand. Well, I have my full head of hair. But it suits you. You're welcome.
Thank you.
Osafo.
Boss, good afternoon.
Akwaba.
Thank you.
Last time I paired the two of you, it came up ironically. You both support Tottenham? No.
I was supporting Tottenham then because of Mourinho.
You've moved?
Yes.
Oh. All right. Thanks for joining me this afternoon. And this area of geriatric medicine, all right, by its label or nomenclature, we're talking about medicine that focuses on the healthcare, health issues of the elderly. Am I right?
Yes, sir.
Mm-hmm.
Yeah.
How do we define the area for our listeners to understand?
So it's a branch of medicine concerned with problems of the elderly, whereby we are looking at how to prevent them, how to treat them, policies and programs you can put in place to address this at a broader scale, and then what should be done at the treatment or the tail end, rehabilitative services as well, and how to include them in society, inclusiveness of our elderly. Okay,
great. If you listened attentively, he said problems of the elderly or the aged, how to identify them, prevent them. You know, we tend to think that as you age, and especially when you get to that age, you must, you will have problems. His intro is telling us that we can actually prevent the onset of some of these and manage them from a preventive perspective. Of course, we want to be able to identify and diagnose and manage these things. And more importantly, he mentioned improving the quality of life of persons in this category. Dr. Enim, do you want to add anything to that?
I think pretty much everything has been said. Once again, good afternoon to our listeners, and I share with your condolence message to the family of Christian Achu and Ghanaians at large. I think, like he said earlier on, the other thing is that it's comprehensive. So many a time, when it comes to the needs of the elderly, we are not just looking at one item as it were, in terms of being biological or medical, you want to go ahead and look at factors like their physical strength, their functionality. So are they able to go about duties which we describe as activities of daily living? Are they able to do that independently or dependent on other people in their household? And they're also looking at things like their cognition. So as they age, they have issues with their memory, sometimes forgetfulness, and then other times maybe they have other symptoms, maybe they're a bit anxious, they are depressed. So trying to put all of this together gives them a certain unique characteristic, and so you need a more comprehensive approach in analyzing their needs in terms of their biological, physical, functional, and then their cognitive needs. So that's what I'll add to it.
All right. So having said all this, with all the lovely bro food, does it therefore validate or justify a special discipline, a special cadre of medical professionals that deal with these issues?
Yes, okay. I think it's important we have, and I must say that sometimes when we discuss these things, oh, sorry, we don't have it in Ghana. But in this case, we do have the training for geriatrics in Ghana. Right. That's being run by the Ghana College of Physicians and Surgeons, headed by one very good professor, Professor Suman. And then we also, by God's grace, last year we had another fellow who graduated, Dr. Lenusia Ahilija. Right. So it's something that is available in Ghana.
We are building the capacity.
Yes, and there are many other residents in training. So it means that in a couple of years' time, we'll have to be discussing how many we can send to different regions. But empirically, we know that there's a difference when people are identified in a geriatric clinic as opposed to a general OPD service. But research has also added on. First of all, research points to the fact that people who access specialized geriatric clinic tend to have improved outcomes. And these outcomes were measured in the matrix of the fact that they have less hospitalizations and then they have less mortalities. And so comparatively, people who sought care in the general pool tend to have more hospitalization than people who did not. To add to that one, there's also improved satisfaction from the patients themselves, because it's a more comprehensive approach. Typically, from where I work in the Kolebu Polyclinic, you have a doctor, you have a nurse, you have a physiotherapist, you have a psychologist attached to the team. So they come and they know that they are not just going to receive a prescription.
Shop.
Exactly.
Instead of the typical thing we see where they are hustling their way around different departments, climbing stairs and doing all sorts of stuff just to seek health care.
And that hits the nail right on the head, because the other advantage that has been documented is that it improves coordination of care. So if this person is supposed to move out to see another specialist, maybe say an orthopedic surgeon, it's not the case where they are moving from one doctor to the other. The kind of care is coordinated between this primary care physician, who's also a specialist, and speaking directly about issues and how to maybe cut down on particular medications, rather than maybe seeking maybe care for hypertension, the condition here, and then going for bone pain here, and going for another condition there. The last but not the least, ironically, is that even though setting up these clinics involve a lot of resources, research that I came across says that generally the cost of care is reduced approximately by 20% when you have these clinics set up. It's very, very cost effective. So those are the things that I'd like to share with the public, the importance of geriatric clinic.
If you just joined us, 17 minutes past your Joy 99.7 FM, Ultimate Health, your ultimate guide to healthy living with me, Naughty by Nature. I'm going to ask them to classify, who falls within the target group. I'm scared because the more I do these things over the years, and I've mentioned that Ultimate Health last week was 20 years, the more the descriptions and the classifications get closer to me, right? But for those of you listening to us, I want you to share. Hey, what is your experience, especially if you are in the target group yet to be defined by age, right? When you go to a health facility, do you get a sense that there's a special, accommodation made for you, right? That makes it easier for you as compared to the average Ghanaian going to a hospital or the hospital? Is there any awareness that you sense and you experience that these guys know how to treat people in my age group, and they make it apparent, they make it manifest, that I actually feel that I receive it? right? WhatsApp is 055 11 11 997. Shortly, I will activate the phone lines. I'm in the studio with Dr. Ernest Mopari and Dr. George Aqua, both from the Kolebu Teaching Hospital. We're talking about geriatric medicine addressing the healthcare needs of the elderly, particularly, emphatically, in Ghana. All right? Because sometimes you read stuff outside and it gives you a different picture. I want us to be meaningfully pinned to the ground here. So coming back, so who would we classify within this geriatric space or span? Who? Is it just an age cutoff? How do we do that?
Okay, so generally anyone 60 and above it falls within that bracket.
60 and above.
60 and above.
Okay.
Yeah, there are no. It varies from jurisdiction to jurisdiction. In some
Right.
places, 60 anyone 65 and above is considered to be elderly.
Right.
And then also, even within this classification, there is a social one which sort of borders more to when you are going to retire from work and all that. So some will say 60 and above, and some even stretch it to 70,
All right.
depending on the life expectancy of that population, the available services to take care of the elderly and all that. So generally anyone 60 or more falls within this age bracket.
Okay. Right. So you know if you're included, or your spouse, or your auntie, your uncle, your granddad, right? There should be some special awareness, provision made for this person, particularly and especially if they're visiting the health facility. Okay. Having said that, in terms of demographics, I know you're in community health, and so, I mean, if we look at Ghana, I tend to know and believe, all right, I stand to correction, that in this category we tend to have a higher representation of women. Am I wrong?
Yes, it's true. Men tend to die before women in our part of the world from various reasons, occupations and their related accidents and injuries. Generally, the health-seeking behavior of men tend to be poorer than that of women. Men in our tradition are socialized to hide pain and trouble and distress and things.
We don't like going to hospital.
We don't like going to the hospital.
Just say it point blank, right? So, gentlemen listening to me, you are likely to die earlier, right? And it is not the devil, okay? We are reluctant to seek healthcare, to report anything, any discomfort and so on and so forth. And this may account for the disparity in numbers.
Yes.
Okay. Women would present if there's something wrong with them.
Yes.
Okay.
And also the female hormones tend to be protective in some situations, especially when it comes to cardiovascular diseases.
Okay.
Estrogen is protective, and it gives women relatively that more or higher advantage as to living longer than men. Right. Yeah. So for these reasons, women tend to outlive men. I don't want to say that women stress men, but then that's what happens.
Right. They're killing us.
Yes.
Years back, they used to say that there are more men than women in psychiatric hospitals, which tells you who's driving who crazy, right? Yeah. But right. So in terms of demographics, we'll see more women in this category.
Yes.
Right. Does it also apply logically, let me put this to Ernest, that the men who present in this 60 and above category would tend to present with more advanced conditions?
To the best of my knowledge, I must say I've not seen any study in that area.
Right.
Probably it's a good area to look into to find out if men who present to the clinic tend to have more comorbidities or more medical conditions compared to the women. But what I must say that despite the trend, the apparent disparity between both gender, there is a steady increment in the proportion of elderly in Ghana. But the last report I read, in 2021, it hovered around 3.5, and in 2022 it came to 3.6, albeit marginal. It's a good indication that perhaps
we are living longer.
So on the global, I think maybe like you said, maybe we need to deconstruct it better. But from what we are seeing, everything put in place, I think we're on a good track. And we need to continue.
Great start. 24 minutes past the hour of 2 on Joy 99.7 FM. We're talking about geriatric medicine, and we're taking our time to lay down the fundamentals, right? We will get into some of the conditions, okay? If you have any questions, concerns to add, share, experiences, WhatsApp is 055 11 11 997. I do believe we are live on Facebook, but there's a problem with the visuals, so you may catch us on Facebook with just audio coverage. YouTube is down. Shortly, I will activate the phone line so that you can ask the questions yourself. So, WhatsApp again 055 11 11 997. Ultimate Health on Joy 99.7 FM. Right. So we've got a picture of those we're looking at. Okay. I said also that many seem to hold the view that as you cross this boundary, be it legal, social, health boundary, 60 and above, you must have challenges, right? There will be a deterioration in your health status, by and large. Are we able to look at common challenges faced by persons in this category? If I were to talk of, well, I don't know whether to rank them or say top 5 or whatever. What are the common things we're seeing the elderly present with in Ghana?
Okay, so this area is well documented both within Ghana and outside Ghana. So in this particular group of people, the elderly, they present with some conditions which are in themselves not a disease entities, but they tend to be a presentation or some it's a condition that is commoner in this age group.
They're more vulnerable to
They're more vulnerable to it. So we describe them as geriatric syndromes.
Okay.
So in this group of conditions are not necessarily a disease where you say, okay, that's a disease, but the presentation is even more so in that population. So from the top, you can think about certain cognitive changes where they are confronted with issues of memory loss. Sometimes they can have not being able to name things. We call anomia, or some other things that we call the neuropsychiatric symptoms, where before they may have what we call dementia, they can have anxiety, depression, and all of that. So those are the cognitive symptoms. The other things that are common in this age group will include falls, because the bones are getting weaker, even though the hormones are still there in terms of the amount of hormones that they are producing, whether male or female, and the ability to provide strength tends to decrease. So falls are very common in this group. Things like constipation. It's also very common in this group. And somebody said, but constipation is not a disease, but it's a big deal if you are in the elderly group. Malnutrition is not a disease entity in itself, but they become more nourished because they either have lost appetite or they are losing teeth or they've lost sense of smell. So all of these are very common things in the age group, but I must say that it doesn't preclude them necessarily from other medical conditions like hypertension, diabetes, arthritis, which are specifics, and they have their own modifications when it comes to their treatment, because in as much as you want to manage them for them to live longer, you also don't want to be overly stringent, because things like diabetes in an elderly person who is not able to eat enough, you have to tweak their diet and tweak their medication. Just over this week, I had a patient like that who's almost an octogenarian, I think almost 80 years, being managed for diabetes. He presented with, sudden loss of consciousness and was found in his office and was rushed in. When I looked at his profile, I realized that he was a patient with diabetes.
80 and he's working. Found in his office.
Yes. So when they rushed him, of course, they didn't know what had happened. So together with the team on duty, he was resuscitated with glucose and everything. It happened that we realized that his blood sugar had gone low, and it was more to do with the doses that he was taking with regards to the insulin. So maybe, having said that they are geriatric syndrome, it doesn't necessarily preclude them from other medical conditions. But these are, on top of my head, these are some of the things that I'd like to share.
So in a cluster, right, a syndromic presentation, we're saying these are more likely to be seen in this age group. You're more likely to fall, you're more likely to have these memory challenges, mood related issues, right? And we need to recognize these things, right, as they present, and be, I guess, more vigilant for them in this age group. Okay, you mentioned something I wanted to pick on now. I've suddenly lost it. I'll come back to it. But I wanted to ask, sleep challenges in this group, would that be part of the syndromic? Because we tend to hear a lot of, we know that as you age, you tend to get, in quotes, less sleep, right? But sleep challenges that are significant enough to affect the person's daily living, are they a key issue?
I agree. I didn't make mention of sleep, but anything in the elderly that, sometimes people will just ignore and say, oh, really, you can't sleep? It's not a big deal. Then you are not sick. But for an elderly person, for anybody who can't sleep, it may be an issue. You have to look at sleep hygiene and everything. Right. But more so for an elderly person who complains they can't sleep, it's a big deal. Okay. Even though I didn't mention it as one of the things. And like I said, it doesn't have to be a diagnosis. Because if the person presents with inability to sleep consistently, there's no need ignoring it because it's affecting their quality of health as it were.
Right. And George, let's come to the other side. Of course, there are clearly diagnosable, identified, or classified disease entities that present in this group as well. What are some of those?
Yeah, so in the elderly, there's a preponderance of cardiovascular disease as a result of accumulation of risk factors from lifestyle.
Okay.
In other words, some of these problems like strokes and heart attacks have their onsets in younger ages. The kind of food we eat, our habit of ignoring regular checks and things accumulates in these things. Also, we have problems of...
Let me just stop you there a bit.
Yes,
okay. Let's take it easy because I always want to keep up with my listeners. When we say cardiovascular, of course... amongst us, you're quickly listing stroke and a few other things. Can you break down cardiovascular? I know what it is, but I want you to break it down so that when somebody hears it, then they know where we're going and the cluster of things we're talking about. Okay, so the cardio comes from the heart, and then the vascular is blood vessels. So we are looking at diseases that affects the heart and blood vessels. Okay. These are commonly stroke, heart attacks, kidney failures. These are the major organs supplied by the heart. So they are systemic issues and they relate to each other. And usually if you find one, in the next minute you are going to find the other. Okay.
Yeah.
Right. So heart health and then, of course, your circulatory system.
Yeah.
Right? That whole system that pumps blood around your body, nourishes, feeds, supplies, organs, key systems.
Exactly.
Right? So when we say cardiovascular, that is broad.
Yes.
Okay, it's a major system.
Yeah.
Right? And you're saying that in the geriatric segment of our population, we have a higher level of some of these conditions.
Illnesses.
Right.
Yes. And they are associated pharmaceutical issues.
Okay.
Because these things are multifactorial, usually underpinned by diabetes, hypertension, and elevated cholesterol levels. It means the elderly are likely to take a lot of medication. They'll take drugs for hypertension, for diabetes, for cholesterol issues, together with other little drugs. So problems of polypharmacy come in here to toxic effects of the multiple drugs they are taking and all that, their side effects, and the need to consciously modulate them.
Okay, let me ask this. When you say polypharm, right, means you're taking a lot of medicine.
A lot of drugs.
Okay?
Yes.
But you're taking them legitimately.
Yes.
They've been prescribed.
Yeah.
Okay. So explain to my listener, when you say polypharm, what is the problem we're talking? Are we saying that you guys are dumping too many drugs on people who need them? What exactly do you mean by polypharma? You're saying that there's a concern about the interactions and the levels of medicines in a person's system. Can you break that down?
Yes.
Yeah.
So basically, people, our elderly suffer from cardiovascular disease. I've mentioned the strokes, the diabetes, and things. And I made mention of the fact that these diseases have multiple etiologies or multiple causes for us to understand simply. So it means in addressing them, we must give drugs to sort out all these causes. And these drugs have toxic profiles. So giving one drug, giving another, chances are that they may interact. Chances are that their toxic effects may manifest at certain levels. So there's a need for us to be conscious about these things.
Okay.
So generally speaking, as we age, we take in more drugs because the issues compound.
All right.
You might have hypertension or diabetes. You may be fortunate to go away with a stroke, but then you might have arthritis of your knee joint or something. You might have dementia or Parkinsonism. You might have eye issues like cataracts and all that, which all these entities require you to take drugs.
Okay.
So by the time you are, say, 80 or 90, if God should permit you to live longer, you might have a basket full of drugs from which you would have to depend on to be able to stabilize your system, sort of, to hold these things back. Now, as you take these drugs come with issues. So we need to sort of
have an understanding and a balance of these things such that you're doing more good than harm.
Exactly.
Right. Okay. If you've just joined us, it's 34 minutes past the hour of 2 on Joy 99.7 FM. We're, taking conscious but steady steps to understand geriatric medicine and some of the issues that we encounter in this segment or spectrum of healthcare delivery. My doctors are taking us through that. If you want to ask a question directly, phone lines active 0302216541. 0302216541. WhatsApp is 05511119997. Ultimate Health on Joy 99.7 FM. We're trying to break down the issues, but feel free to share yours when you join us by WhatsApp or direct phone call. The Facebook feed, I believe, is active, but may possibly or likely be on audio only due to a challenge. We have a technical challenge. Unfortunately, also, our YouTube is also challenged. We apologize for those, but I know my discerning listeners will join us. 0302221651. Ultimate Health on Joy 99.7 FM. We're listing the other conditions. Now, I noticed the diabetes came up alongside the cardiovascular. Right. Somebody may want to ask, is it a cardiovascular disease? Is it an endocrine? What is it?
Yes, it cuts across.
Okay.
It cuts across. It has a direct bearing on the heart and these organs I've talked about, which constitute the cardiovascular diseases. And also in the endocrine area too. Diabetes is a disease resulting from malfunctions of insulin. Insulin is one of the hormones in the body. Its job is to push glucose into cells for storage. For some reason, they become defunct as we grow, and this results in a persistent rise in blood sugar, and we call this phenomenon diabetes.
Right. Okay. Right. So apart from these ones, any others that we... Did you mention the cancers or? Yes,
cancers. Cancers too are quite common in the elderly. They also begin. The risk factors start when we are much younger and they progress. Commonly in the elderly, we have in the males prostate cancer, and in the females cervical cancer and breast cancer. Right. These are quite preponderant in the elderly too.
Okay, 37 minutes. Oye, I see your welcome message as usual. Glad to be welcoming your home, Oye in Afienya. What's this one saying? Lost this one. Okay, good afternoon, Norte. Which part of Kolebu is geriatric care unit located? Which other hospitals in Ghana have a geriatric care unit?
Okay, so in Kolebu, the geriatric clinic is run weekly at the Kolebu Polyclinic. I must say that for now, it's based on appointment. So you'll have to come in and then have an appointment before. Like I said earlier on, I know Dr. Lenuzia Ahilija in Tema Polyclinic as well. And I know there are many other senior residents, including Dr. Kwesenu, who are in training. So I'm sure pretty soon we would have many more of such clinics.
Okay, so if you're aging, just slow it down so that you can catch up with the number of specialists we have. But that's a serious consideration. And I know for doctors considering their professional development and specialization, this is an area. But also, it's interesting that, we have the College of Physicians offering these things, but when we come to facility level and maybe policy level, there's a gap, right? That we should have been doing this over the years. It's been there. It's a discipline that's there. But we're now catching up and hopefully attracting the needed attention, right, and numbers from your colleagues. That's an important thing, because we are getting a higher and growing percentage of older persons, and we must meet this demand, this need. Okay, so it's not just about having programs like this. The resource must be there on the ground, and then we must be making the health impact. Dede said, did he just go there? The stress from women is one of the many reasons men die early. Oh, come on, Dede. You see, you are even stressing us on the WhatsApp. Dede, but we won't die. We'll respond. He said, did you just go there? When we're talking about the disparity in numbers, okay? We're trying to give our listeners a sense of the profile of the spectrum we're looking at. Good afternoon, please. Is it advisable to be taking supplements at the age of 60 and above? Supplements,
Yes.
We like supplements and tonics and mujadro and all sorts of things. Do we really need them and at this age?
Yes, we do. So as we grow, the body's ability to make use of vitamins and micronutrients generally declines for various biological reasons. The number of enzymes to process them go down, inherent more nutritional problems, etc., etc. So as we grow, there is a need for us to supplement our diet with certain nutrients. Commonly the B vitamins, and then also vitamin C, folic acid, and things for building up iron reserves, zinc, and all these. They are micronutrient deficiency problems as a result of us not taking enough of these nutrients, and they also present as illness. So it's very important that as we grow, we take supplements.
All right.
Sorry, I just wanted to add this quickly, especially in this age group where they have children or grandchildren who may be living outside. One of the practical, because we are situating this conversation in the context of our country, one of the social context that we have is that they are outside, they hear this supplement is good. Grandchild A buys this supplement from another country, another child buys this. The elderly person, him or herself in this country, is buying another. And for some reason, something that they can take all three at the same time. Supplements are there, as Dr. Akwa just mentioned, are what they are. They are just supplements. They are supposed to add on to what you're already taking. So you just have to know the composition, because he also mentioned something about polypharmacy. So the fact that you are taking more supplements in itself doesn't necessarily mean that you are doing well. For any reason, that's why we run the geriatric clinics and have this care, because sometimes you can have a particular supplement that tends to have almost all the composition that you need, rather than take one that is maybe for iron, another for calcium, another for magnesium, vitamin D, which are all very essential. So you can go to the market and find one that would contain an appreciable amount of these nutrients, and can be a single pill as well, so that you lessen the pill burden in this group.
Right. Okay. And talking of pill burden, and I know at that age, remembering your medicines, remembering the name of medicines, having a pill dispensing tray, which is labeled by day, sometimes even by hour and time, helps, right? In other parts of the world, I know there's a lot of concern about even the containers the medicine is in for the elderly, right? So there are certain types of bottles they can't open or have a difficulty with. There are certain types of pill pouches and so on and so forth. Are we that should I say vigilant in our part of the world? Because I know in other parts of the world these are things that you look out for, and you make sure. Especially we tend to think in our part of the world that the elderly would not be living on their own, but they very often have to contend with these medicine-taking requirements on their own. Are we that fastidious about these things?
Yes, it's a phenomenon that's well documented. Yes. However, in our context, we don't have that. We call it the black polythene, like you said. So when you ask them, please, did you bring your medications along? Then they just pull their bag, black polythene with all the medication that they've taken over ages. So it's one of the things that we do in the clinics to make sure that they bring their medication, because over time, as has been said early on, maybe they may have been on one particular antihypertensive or medication to control their blood pressure, and then it wasn't working and it was changed by another doctor. And maybe if the explanation doesn't go well, they tend to take all of these together. So one of the very first things that is done in the clinic is that, Madam, sir, please, did you bring any medication? Then they pull out their polythene bag. If only you ask them, because before you even try and write a painkiller, you'll be surprised how many painkillers that they are taking all together. So it's one very key thing that we do, which here we call it the black polythene.
Right. Okay. I tend to ask them if they can. Many are quite comfortable on social media. Take a picture of all your medications and send to me. Yeah. Then I'm able to actually ask, well, when did you start taking this one? I'm not aware of this one. Oh, my nephew brought me this, or a neighbor brought this. This is a ginseng, this is a that. And at this age group as well, or in this age group, this is something we need to be aware of, even though the younger people also do this, right? It's important that we manage their management of their medicines, and make sure that they are able to do that. In other parts of the world, I know that they sometimes find with the elderly and maybe the less educated, the need to tie drug taking regimens or times to times of the day and activities in the day to help them remember. Right?
And also pill minders. These are plastic containers with days and times for each drugs written clearly on them, so it makes it easy for them to follow. These are readily available in almost all our big pharmacy shops.
Right. So use these, and those who are competent and conversant, there are apps on your phone that also help you to manage your medications. All right. So typically, this question also comes up. If I am in the age category we're talking about, I don't really think I have any health issues. Do I need any routine assessment review? I think I'm fine, all right? We know in our part of the world there are people who don't know their numbers, they don't know their blood pressure, they don't check sugar, and so on and so forth. But I'm generally fine, and I think I look and feel okay. I'm listening to you right now. Should I head to some facility and ask for the geriatric unit and have an assessment?
Yes, certainly, because the assessment of this group is comprehensive. Like I said earlier, it's not just about your, your physical parameters. Even if you checked your blood pressure, you checked your weight, you checked your blood sugar, there are things like function, which may look simple. For instance, are you able to answer your phone, or do you have to tell somebody to make calls for you? That may be simple in the eyes of many people, but in terms of functionality, it points to the fact that you have a certain limitation. The other side have to do with maybe your vision. So you may not be wearing glasses, or you may not even have an issue seeing entirely, but you realize that you are falling every now and then. So those are the tiny bits that makes it important for a comprehensive geriatric assessment to be done, because it is not just the physical component, it comprises your whole being. And perhaps maybe you are fine, but you are just feeling lonely at home, and that's a cause of worry for us.
So
in the
there's a
geriatric
whole,
clinic.
or should I say, a 360-degree assessment that is done for the elderly person, to make sure that you're looking at their social circumstances, their psychological adjustment, right? Other things, even finances sometimes come in, right? Because you may do an assessment, and because of the financial requirement, that's the last time you're going to see this person. So all these go into a full geriatric assessment. Okay. I can see Dede typing in Maryland there. Phone lines are active: 0302-216-541. Ultimate Health on Joy 99.7 FM. WhatsApp is 055 11 11 997. We're looking at geriatric medicine, and we're tiptoeing into the issues and some of the common presentations as well, with Doctors Ernest Enimo-Parry and Dr. George Aqua. George Aqua is a resident in community health or community medicine. Community
same thing.
Yeah, same thing, right? Kolebu Teaching Hospital. And Ernest Enimo-Parry is a specialist family physician with the Kolebu Polyclinic Family Medicine Department. If you have any questions, concerns, I've got them locked down here in Kokomemle, you can call right now and they will have to answer you. Right. So these are important things we need to know. And typically at a geriatric clinic, let me ask this before I ask what I'm going to ask. If you go to a health facility and there is no such department or unit, can the average GP or doctor, physician see you?
Yes. Geriatric care is an essential part of general care. So every doctor, every physician in training is taken through not necessarily geriatrics, but all the problems the elderly will encounter. So they have enough competence, enough knowledge to address geriatric issues.
Okay.
Yes. So they can give you preventive care as well as treatment of their issues too as well.
Right.
To include rehabilitation services and all that.
Okay.
Yeah.
Right. So would that mean then, right?
Yes, sir.
Taking into cognizance your earlier definition and the characteristics of this area, which says that one-stop shop, we're not going to have you queuing all day long and all that. Does that mean that if you're seeing somebody within the general system, then despite your age, you will be going through the queues and the long waitings and the referrals and so on and so forth?
Yes. With regards to the queues and the referrals, it's got to do with how our systems are structured. So ideally, the elderly should be prioritized because their tolerance or threshold for stress is much lower. And for instance, if you have an elderly person in the queue waiting to get his blood sugar checked, chances are that he might tip into hypo, and that could be something else, whilst the younger people will be strong enough to stand that. So it's imperative that we prioritize the elderly people.
Let me push you to the wall. Right? Okay, let me push you, George.
Yes,
Dr. George Aqua, to the wall. When we say prioritize, it sounds nice, it sounds lovely.
Yeah.
How do we operationalize that? What does it mean in a clinic setting?
Yeah.
Right? Does it mean somebody comes and looks around or looks at the folders and, stacks those with higher ages on top so that they'll be seen? What does it properly mean? How do we operationalize this?
Yes, for this to be operationalized.
Because I'm looking at a situation where folks listen to us, right? Thankfully, they listen to us. But they go and say, hey, I listened to Norte and the doctors yesterday. You are supposed to see to me first, right? How does it work?
So, first of all, we need policies from upstream. Yes, sir.
So they are absent.
These policies are, I would say they are not clear cut.
Okay. This is why I pushed you to the wall, okay? So that we know that I go to Kolebu, what George says is, okay, I won't use that word, but it doesn't happen.
Yeah.
Right? How do you translate this to daily care for this category of people?
Yes, the policies should spell out prioritize care for the elderly.
Okay.
That's the first thing. And then two, at the patient's end, patients should proactively demand that my 95-year-old grandmother or grandfather is quite frail. So could we see him or her before seeing the much younger people? And then the practitioners too must buy into the idea and then be able to help these policies to roll out smoothly.
All right, phone line still active, 0302216541. I pushed them to the wall, but I know you guys do it better. So you can call. Dede says, don't some of the medicines, such as those for cholesterol, contain vitamin C, such that taking supplements increases the dose for the daily intake? This is why I think Dr. Nimo Pari was saying we need to know what you're taking, the constituents of the supplements and so on and so forth, and help you streamline, and maybe even dump a lot of them that you may not need, so that you don't have duplications and overdoses and the resultant complications. She's still typing. Okay, that's Dede, right? Dede, when you get to 60, I'll see how you type. Are you 60 or not? I don't know. All right. Okay. So we talked about diet and we talked about supplements. All right. Many people feel, and especially in this age group, that the fact that I'm taking supplements, I'm okay, and therefore they rather compromise their diet. their primary nutrition, right? They're not eating that well, but they think they can make up for it with these supplements, which are widely available and accessible. I'm asking about that, and I'm also asking, sometimes we get cases in the geriatric realm where nutrition is compromised. I think Dr. Enimopari mentioned it, based on dentition. I've lost some teeth, I have challenges chewing, and so on and so forth. So I'm not eating that well. How do we balance these? Because many people feel the solution is the supplements.
Yeah, so with regards to the supplements, we've already iterated the fact that we are taking it not because you necessarily need so much, but because your body has lost the ability to tap into food.
Okay.
So first of all, you're not able to chew properly because of dental issues.
Right.
Dentulism, a phenomenon whereby you lose teeth as you grow, and you can't do much about that. Secondly, the slow transit time of food, low level of enzymes to process it, and all that. So it's important that you take these supplements so that they can hit the bloodstream and then make up for the deficit.
Okay. Right. All right. That's important for you to understand. Did they ask? Okay, well, we've dealt with that. Right. So mobility, right? We talked about falls, but there are many of these people who can't move like they used to move, right? Is this an issue, and how is this addressed? Is it part of an assessment?
Yes, so there are several modalities for assessing mobility in the elderly.
Okay.
So some of the modalities include a test called timed up and go, in which case the patient is made to sit and then walks for 3 meters and then turns around. The person is supposed to make all of that movement in a straight line without bending so much in about 20 or so seconds. If the duration is exceeded, it's an indicator that the person's mobility is impaired in a way.
Right.
And there are other things that will tell us that a person has impaired mobility.
Okay.
And that's why in a typical geriatric clinic, it's not just about the physician. It's also about having the physiotherapist in there, occupational health therapist in there, having a social worker.
Right.
Because sometimes it could be some other thing other than the musculoskeletal in itself. So it's one assessment parameter that we do. That's why we think that even if you think you are fit, it's good to have a thorough assessment in the geriatric clinic.
Okay, so we can actually have you assessed, and we look at your mobility, right? Your ability to independently move around, right? And there are ranges or norms that would indicate whether you are okay or you are compromised.
Yes.
In that regard.
Yes.
And then the necessary interventions can be, should I say, indicated and undertaken. So it's very important, right? Can I go up the stairs? I don't have stairs. Can I move around in my social space, and so on and so forth, right? And you mentioned assessment of vision as well earlier.
Yes. Okay. Yes. So mobility is a function of a lot of things. So apart from the musculoskeletal, of course, the vision. So if the person is not seeing well, they are likelihood to move out of wherever they are because of a certain apprehension to fall.
Okay.
Or if they have impaired hearing, if something drops on the ground and they cannot easily find their way out, all of that can impose. And of course, the other reasons why they may not move, because they may have things like vertigo, which is a form of dizziness. So it's a complete thing that when you are doing, you are looking at other variables that could factor into a person's impaired ability to mobilize from one point to the other.
Okay. Right. My ability to cut this into segments for future programs is not impaired, right? And I'm looking at the clock while saying that. But it's important. So I'm just going to ask this as we wrap up for today. We'll look at other slices of geriatric medicine in the weeks to come. But are you able to do all this? I know when we talk of the discipline, right? The know-how, right? The skills are there. But I'm looking at a typical consulting room in Kolebu and elsewhere. I'm looking at Ernest asking somebody to get up and walk and go and come. And then he'll be assessing mobility. Let's speak to the real facts, because, sometimes the policymakers, they frustrate us. But in reality, do you have the space within these specialized units, few as they may be, right, to do all these things that we are talking about? It sounds lovely to my listeners, But really, I mean, you're going to ask my mom to get up, take a walk, take a stroll, do this, do that. Then you bring in an OT. Then you bring in this person. The social welfare comes in. Are you able to do that?
Thankfully, in Kole, we're able to do that. We have a consortium that gives us the opportunity to do that. And that's why I said earlier that we run a scheduled system because, the assessment is quite comprehensive. Okay. So if you're going to take about a little over an hour to see a patient who is just enrolled in the clinic,
right,
there's so much, there aren't so many patients you can see.
Right.
So it is possible.
Is it by appointment? Can I just walk in?
So you can walk in. If the main thing is that it shouldn't be an emergency.
Right.
It should be somebody who maybe doesn't have any medical difficulty. If there is any such difficulty, then the person will go through our emergency triaging system.
Okay.
But if the person has been seen and is stable, sometimes you refer patients to the geriatric clinic, even within the polyclinic, which means that the person is okay and is now going to be assessed thoroughly. So because of what you just mentioned about the space and time, obviously you can't see everybody. So even though you'd love many people to come to us, I must say that it's not going to be a situation where you just walk in and you are seen. Okay. Because people would have booked ahead of time just to make sure that
so
they are
you can book.
Yes,
and
you can
should book.
Yes.
And you will be booked.
Yes, you will be booked.
All right.
So there's a particular number of people that are seen on a particular day. Yes.
Otherwise, there'll be a flood of patients and will compromise your mobility. Right. Almost a minute left. Just about a minute left. We'll have to take our time to look at some of these things. By all means, Ultimate Health does diabetes, cardiovascular diseases, and so on and so forth. But I want us to make some time to dedicate time for these conditions as they present in the elderly and look at the way they are managed typically in our healthcare setting. I don't know whether there's anything you want to add, George, before we leave.
Okay, so one common problem among the elderly men too is erectile dysfunction, and thankfully there are various treatment modalities available.
Can't they just resign, retire?
It's a bit difficult for the men to retire, but then we can help them as they are growing.
Okay. I thought a psychologist could convince them that, right? But it's a big problem. I understand. So you look at some of these things as well.
Yes.
I guess that's why, a pharmaceutical giant will get up and create something like Viagra and all these kinds of things, right? Yeah. So you may have a weak heart, but down there you are strong. We need to balance the two, because some people take these Viagras and other things. I'm sorry I'm mentioning a brand name, okay, but there are several now. And then they pop up because they put pressure on their heart. Yeah. Okay, so we'll need to talk about those for the men, right? Sure. It was Dr. Aqua who brought that up. It's an area of concern for him. Not kindly ask your guest to advise what diet increases libido. I am 45 and gradually losing it. Okay, then you need a full assessment and not just diet. Okay, because you're doing, probably there's other things. Sometimes if you're saying loss of libido or erectile dysfunction or challenges, what we call impotence, not infertility, then you may also have other conditions playing around in there. Yeah. So it's not just your diet. I'm sure if you get the chance, you'll take something to have 10 minutes of glory, but there may be some underlying causes. Or my docs.
Yes. So certainly
45.
So I mean, libido has a lot of. It's part of a spectrum of sexual dysfunction. So it could be psychological, and the thing about the psychological bit is that it's a cyclical way where the anxiety of having low libido fits into not performing or having erectile dysfunction. So the moment you even think about it, you are discouraged because you think you are not going to perform. Okay. And then there could be other medical conditions that you mentioned, hypertension, diabetes.
All righty. We've actually done 2 minutes past 3 o'clock. We have to wrap up. Is it advisable to add apple cider vinegar to one's diet? My mom was a strong proponent for this because it helps in your sugar levels, pressure, digestion, etc. She'd also read so many books on this, right? Any comments, or we leave that?
I don't know about how cider vinegar can regulate the role it plays in blood sugar regulation. It could just be a supplementary one, but for blood sugar control, you need to take your diabetes medicines, and they must be monitored and supervised in clinic. Okay. Yes, all these other cider things are all supplements.
Okay. Yeah. Great stuff. Many thanks, Dr. George Aqua. community health resident or community medicine resident Kolebu Teaching Hospital, and Reverend Dr. Ernest Enim Opare Osofo, and specialist in family medicine at the Kolebu Polyclinic. We'll have you guys in again next week and break down some of these issues. Many thanks to my discerning listeners.